Before we start, please like, comment, and subscribe. It helps the channel grow and reach other nursing students who could use this info too.
All right, let's dive into the incredible system you've given us, source material, on the heart and the vast network of vessels it pumps through. It's really like the body's essential engine room and, the high-day system keeping everything moving.
It really is a truly complex and vital setup. And the material you've shared, it's like a detailed map, isn't it? Full of key facts, insights into how this machinery operates, and maybe more importantly, what happens when things go well, of course.
Exactly. And our goal with this deep dive is to navigate that map together. We want to pull out the most important bits of knowledge and really help you understand the core mechanics, the health implications, all drawn directly from the details you provided.
Yeah, getting to the essential understanding.
We're not just skimming. So let's start right where it all begins. The pump itself, the heart's action.
Absolutely. The physical act of the heart contracting, pushing blood out. And a core concept here is stroke volume SV. That's just the amount of blood the heart ejects with each single beat.
Okay, stroke volume. And the sources really help break down what influences that volume, right? Using some pretty good analogies. First up, preload.
Preload. Yeah, it's essentially how much the heart's chambers, the ventricles, fill with blood before they contract. The analogy used is like filling a balloon with water.
Okay.
The more water, the more the balloon stretches. So preload is about that stretch on the ventricle walls as they fill up. And it's heavily influenced by how much blood is returning to the heart from the body, the venous return.
So more blood coming back means more stretch, which means higher preload.
Precisely. And that increased stretch up to a point often leads to a stronger contraction afterwards. It's sort of priming the pump.
Got it. Then there's afterload.
Afterload. This is the other side of the coin. It's the resistance the heart has to pump against to actually get the blood out.
Like squeezing that water balloon, but there's resistance at the neck. Makes it harder to get the water out.
Exactly that analogy. What affects this resistance? Well, things like your overall blood pressure, for one. Also, how stiff or flexible your arteries are and resistance within the smaller vessels.
Okay.
And a crucial takeaway here. Simple, but really profound. Lower afterload means it's easier for the heart to eject blood. Makes sense, right?
Yeah.
Whereas higher afterload means the heart muscle has to work harder every single beat.
Which you can imagine over time puts a lot of strain on that muscle.
Yes.
Okay, and the third element affecting stroke volume is contractility.
Yes, contractility. This is about the inherent strength of the heart muscle's squeeze itself. Think of a rubber band snap. It's the muscle fiber's intrinsic ability to shorten and contract forcefully. This would be influenced by, say, hormones or certain medications.
So stroke volume, the amount pumps per beat, depends on the filling, preload, the resistance it pushes against afterload, and the muscle's own power, contractility. And the sources briefly mention cardiac output. The total volume per minute is just heart rate times the stroke volume.
That's right. Now, stroke volume covers the mechanical action, the pumping. But that coordinated squeeze isn't just random. It's all orchestrated by a pretty sophisticated internal electrical system.
Moving from the plumbing to the wiring.
Exactly. Let's get into that. The heart's natural electrical grid. The sources lay out the components of this conduction system really clearly. It controls the rhythm, the timing of the contractions. So where does the signal start?
It starts at the top, right? The SA node.
Correct. The sinoatrial node, or SA node. This is the heart's main pacemaker. It naturally generates electrical impulses, usually at a rate somewhere between 60 and 100 beats per minute in adults at rest. And this initiates the electrical activation, the depolarization of the heart's upper chambers.
Okay, pacemaker starts it off, and then that impulse travels down to the AV node, atrioventricular node.
That's the one. The AV node. It acts like a crucial gatekeeper. It has its own slower inherent rate, but its most critical job, highlighted in the sources, is to actually delay the electrical impulse for a tiny fraction of a second, about 0.04 seconds.
A delay. Why would it need to pause?
It's all about timing. It's essential. The sources explain this brief pause is perfectly timed to allow the atria to finish contracting and push their blood down into the ventricles before the ventricles get the signal to squeeze.
So it makes sure the ventricles are full before they pump.
Exactly. Ensures they're fully loaded for maximum efficiency, maximum cardiac output. Once that signal passes the AV node, the atrial electrical part is done.
Okay, smart design. Full tank before the big squeeze. After the AV node delay, the signal moves into the bundle of HIS.
Yes. And right there, the impulse conduction speeds up again, resumes rapid travel. The bundle of His is where the signal really starts its journey into the ventricles, initiating ventricular electrical activation, and it quickly splits into the left and right bundle branches.
And these bundle branches, they carry the signal down through the walls of the ventricles.
Precisely. Down they go. And here's a neat little detail the sources point out about efficiency. The impulse actually travels a bit faster down the left bundle branch.
The left. Why the left specifically?
Because the left ventricle wall is much larger and thicker, remember. It has the bigger job of pumping blood out to the entire body. So this slightly faster conduction on the left helps ensure that even though it's bigger, both ventricles contract almost simultaneously. Very efficient.
That is fascinating. Okay, and the final step in the wiring, the Purkinje fibers.
Right. These are the fine fibers that spread out from the bundle branches deep into the heart muscle, the endocardium. They rapidly distribute the impulse throughout the ventricle walls, triggering the coordinated contraction. They also help with the electrical reset afterwards, the repolarization.
They have their own rate, too.
They do. Quite slow, like 20-40 BPM, similar to the bundle of HIS. But their main job is that rapid conduction. The sources mentioned they can act as a backup pacemaker system if the higher-up nodes fail or there's a block, but usually that's an emergency backup.
Okay, so recapping the electrical flow. SA node starts it, AV node pauses for filling, then rapid fire through the bundle of HIS, the bundle branches, and the Purkinje fibers to make the ventricles contract together.
You got it. Now, how do we actually see or listen in on this electrical conversation happening inside the heart?
That would be the ECG, right? The electrocardiogram.
Exactly, the ECG. Those familiar squiggly lines on the monitor or paper strip. An ECG is essentially just a tracing, a recording of this electrical journey as it moves through the heart muscle, detected by electrodes on the skin.
And the sources show how the different bumps and spikes on a normal ECG, what they call normal sinus rhythm, directly correspond to those electrical events we just talked about.
Right. So that first little bump you usually see, the P wave, that represents the atrial depolarization, the electrical signal spreading through the atria, starting from the SA node.
Okay, P wave is atria, then the big sharp complex, the QRS.
That's the main event, electrically speaking. The QRS complex represents ventricular depolarization, the signal rapidly spreading through the ventricles, starting from the bundle of HIS and going through the Purkinje fibers. This triggers that main pump contraction.
Makes sense, it's bigger then. And the T wave that follows.
The T waves represents ventricular repolarization. That's the ventricles electrically resetting, getting ready for the next beat.
Yeah.
It's associated with the activity in the Purkinje fibers during that recovery phase.
So P wave, atria firing, QRS, ventricles firing, T wave, ventricles resetting. Simple when you break it down.
Pretty much.
Yeah.
And the sources also give us some basic steps for looking at an ECG strip. You check the heart rate is in the normal range, usually 60 to 100. You check the rhythm, are the beats evenly spaced, regular, and you confirm all the waves P, Q, or S, T are present and look generally okay.
And they emphasize that the timing between these waves is really important, the intervals.
Crucial. They mention specific normal timings to look for. For instance, the PR interval, that's the time from the start of the P wave to the start of the QRS complex, should normally be between 0.10 and 0.20 seconds. It reflects that AV node delay. And the QRS complex itself, representing how long it takes for the ventricular signal to spread, should be quick, normally less than 0.12 seconds. If these intervals are too long or too short, it tells you something might be wrong with the conduction system.
Right, deviations are clues. So, okay, we understand the heart as a pump, its electrical control system, and how the ECG lets us watch that electricity. But what happens when that carefully timed electrical rhythm goes wrong?
Well, that leads us directly into the topic of dysrhythmias, or sometimes called arrhythmias. These are basically disruptions or deviations in the heart's normal electrical pathway, causing problems with the rate or the rhythm.
And the sources list a whole bunch of things that can cause these disruptions, right? It's quite a range.
It really is. Things like, simply getting older,
Right.
having had a previous heart attack, an MI, chronic high blood pressure, heart valve problems, heart failure itself, conditions affecting the heart muscle like cardiomyopathy, certain infections, diabetes.
Yeah.
Even things like sleep apnea or electrolyte imbalances can throw the rhythm off.
Wow. And also lifestyle factors.
Absolutely. Recreational drug use, cocaine is mentioned, excessive alcohol, tobacco use. And sometimes it can be a side effect or toxicity from prescribed medications, like digoxin toxicity is listed as a potential cause.
It really highlights how many different things can interfere with this quite delicate electrical system.
Definitely. And the sources give specific examples of common dysrhythmias, starting with ones that primarily affect the heart rate.
Like sinus bradycardia. Brady means slow, right? So heart rate too slow.
Exactly. Rate less than 60 beats per minute. The sources mention causes like vagal stimulation, things that stimulate the vagus nerve, which naturally slows the heart, or certain medications, particularly negative chronotropic ones like calcium channel blockers, beta blockers, or digoxin, which are designed to slow the heart rate.
And it notes that for some people, like trained athletes, a slow heart rate can actually be normal, right? Their heart's just very efficient.
That's a key point. Yes. So if someone has bradycardia but feels fine, has no symptoms like dizziness, confusion, fatigue, shortness of breath, especially if they're an athlete, the source material is quite clear. Often no action is needed.
But if they are having symptoms,
Then treatment might be necessary. A medication like atropine could be used to speed the heart rate back up.
okay. And the opposite, sinus tachycardia, tachy means fast.
Right. Heart rate over 100 beats per minute. The list of potential triggers here is also long. Fever, anemia, hypovolemia, low fluid volume, hypotension, low blood pressure, a pulmonary embolism, clot in the lungs, an MI, even just emotional stress or exercise.
Yeah.
Also things like hyperthyroidism or stimulants, caffeine, cocaine, certain meds like anticholinergics.
And symptoms feel like your heart is racing, palpitations.
Yeah, palpitations, maybe shortness of breath, headache, dizziness. The main approach here, according to the sources, is usually to figure out and treat the underlying cause. If it's fever, treat the fever, dehydrate, give fluids, manage the stress. Medications like beta blockers or calcium channel blockers might also be used to help slow the rate down if needed.
Okay, so those are rate issues, but then things can get more complex with the rhythm itself, like atrial fibrillation or AFib.
Ah, yes, AFib. This is described as the atria, the top chambers, just sort of twitching rapidly and chaotically instead of having organized contractions. It's very common, especially as people get older. Risk factors include things like cardiomyopathy, long-standing high blood pressure, valve disease, obesity, diabetes, chronic kidney disease, previous cardiac surgery, coronary artery disease, even significant alcohol consumption.
And symptoms, can people feel it?
Sometimes they might feel palpitations, shortness of breath, maybe dizziness or chest pain. But interestingly, the sources note that many people with AFib can actually be asymptomatic. They might not even know they have it.
That seems dangerous if it can cause problems. And treatments.
Treatments aim to control the heart rate, sometimes convert the rhythm back to normal using medications, antiarrhythmics, or procedures like electrical cardioversion or ablation. But the sources really emphasize the serious complications that can arise from AFib.
What are the main risks?
Two big things. First, because the atria aren't squeezing effectively, there's some loss of cardiac output, which can contribute to fatigue or heart failure symptoms. But the most significant risk highlighted is the formation of blood clots.
Clots? Why clots?
Because the blood isn't being pumped smoothly through the atria. It can become stagnant in those twitching chambers, especially in a little pouch called the atrial appendage. Stagnant blood tends to clot, and if one of those clots breaks off...
It can travel anywhere.
Exactly. If it goes to the brain, it causes a stroke, CVA. If it goes to the heart's own arteries, a heart attack, MI. To the lungs, a pulmonary embolism, PE. To the legs, a DVT. This high risk of clots is why anticoagulation, blood thinners, are often a cornerstone of AFib management. Understanding that connection is critical.
Wow. Okay, that really underscores the danger. Let's move down to the ventricles then. Ventricular tachycardia, or VT.
VT. This is when the ventricles, the main pumping chambers, start firing off abnormal impulses very rapidly, essentially taking over as the pacemaker. It's typically defined as 3 or more consecutive fast beats originating from the ventricles.
And causes are usually pretty serious.
Generally, yes.
Yeah.
Things like severe hypovolemia, hypoxia, lack of oxygen, acidosis, blood to acidic, electrolyte problems, especially potassium being too high or too low, hypoglycemia, hypothermia, certain toxins, cardiac tamponade, fluid squeeze in the heart, and MI, PE, digoxin, toxicity, or stimulant use.
Symptoms. Can you be asymptomatic with VT?
The sources say people might feel palpitations, shortness of breath, dizziness, or even lose consciousness. It might start asymptomatically, but it's unstable and will likely become symptomatic quickly. It's a dangerous rhythm.
And treatment really depends on whether the person still has a pulse, right?
Absolutely critical distinction made in the sources. If there's VT with a pulse, the person is still circulating some blood. Treatment might involve antiarrhythmic medications, correcting electrolyte imbalances, or synchronized electrical cardioversion.
But if it's pulseless VT?
That's a cardiac arrest situation.
Yeah.
The sources are clear. Immediate CPR and defibrillation are needed. Call a code blue. Start emergency protocols.
Which leads us to the most chaotic one mentioned, ventricular fibrillation, VFib.
VFib. Here, the ventricles aren't just beating fast, they're just quivering or fibrillating randomly, completely uncoordinated. They aren't pumping any blood effectively. The sources state this very directly. VFib is a lethal dysrhythmia.
No blood flow at all.
Essentially none. Causes are similar to the severe triggers for VT. MI, hypovolemia, hypoxia, acidosis, major electrolyte problems, hypothermia, toxins, drug overdose, electrical shock, cardiac tamponade.
And the required action is immediate.
Absolutely immediate. There's no time to waste. The sources say, start chest compressions, CPR, immediately and use defibrillation as soon as possible. That electrical shock is the only thing that can potentially stop the fibrillation and allow a normal rhythm to restart.
Okay. So we've covered the pump mechanics, the electrical control, how we monitor it with ECG, and the serious consequences when that electrical system malfunctions, leading to various dysrhythmias. But the heart isn't just electricity. It's muscle, valves, and it sits in a sac. The sources also dive into conditions affecting these structures.
Right. Starting with the big one, coronary artery disease, CAD. This is fundamentally about the arteries supplying blood to the heart muscle itself. They get narrowed or blocked.
Usually because of atherosclerosis, right? That buildup of fatty plaque inside the arteries.
That's the main culprit. And the sources list the risk factors, helpfully splitting them into modifiable things you can potentially change and non-modifiable.
So modifiable would be things like high cholesterol, high blood pressure, diabetes, being overweight or obese, smoking, not getting enough physical activity. Even things like air pollution and social determinants of health are mentioned.
Yes. And the non-modifiable ones are things you can't change. Your genetics or family history, your age, biological sex, race.
And how does CAD typically show up? Chest pain, angina.
Angina is the classic symptom. The sources describe different types. Stable angina, which is predictable, comes on with exertion or stress, goes away with rest. Unstable angina, which is more serious because it can happen unpredictably, even at rest, or is worsening. And then Prinzmetal's angina, which is caused by spasms in the coronary arteries, often happens at rest, sometimes in clusters, frequently at night.
And managing CAD involves lifestyle changes, medications, assessing chest pain carefully, maybe oxygen, ECGs during pain, and sometimes procedures like angioplasty or bypass surgery.
Exactly. And this is where the sources bring in that case study, Mr. Smith. His stage I hypertension, that elevated blood pressure, is directly linked back to the concept of increased afterload.
Right, making the heart work harder.
Yes, increasing the cardiac workload, stressing his vessels, and putting him at higher risk for heart disease, including CAD. And his other factors being overweight, his diet, his history of drinking, are pointed out as those modifiable risk factors for CAD that he could potentially address.
It really connects the dots between those basic physiological concepts and real-world disease risk and lifestyle.
It does. The sources also cover several inflammatory and infectious conditions that can affect the heart.
Like infective endocarditis, infection of the heart's inner lining.
Exactly. Inflammation of the endocardium, often involving the heart valves. Usually caused by bacteria, sometimes fungi. Key risk factors highlighted include having damaged heart valves already, being older, over 60, being immunosuppressed, IV drug use, untreated strep throat, and interestingly, a very important one emphasized is poor oral hygiene.
Really? Oral hygiene?
Yes. Bacteria from the mouth can potentially enter the bloodstream, especially during dental procedures or with gum disease, and travel to the heart, sticking to damaged areas.
Wow. And the signs of endocarditis can be quite specific.
They can be. The sources mention Osler's notes, painful reddish lesions, often on fingers or toes, Janeway lesions, small, non-tender patches on palms or soles, splinter hemorrhages, tiny blood clots appearing as lines under the fingernails. Also, fever, fatigue, maybe confusion, and critically, a new or changed heart murmur because the infection is often damaging a valve.
Okay. Then there's myocarditis, inflammation of the actual heart muscle.
Correct. Inflammation of the myocardium, the middle muscular layer, is often triggered by viral infections. And a striking fact from the sources, myocarditis is noted as the third leading cause of sudden cardiac death in young athletes and is generally more common in men.
That's sobering. How does it manifest?
It can present with signs of heart failure, cardiogenic shock, where the heart suddenly can't pump enough blood, chest pain, or those dangerous dysrhythmias we discussed earlier.
And pericarditis. Inflammation of the sac around the heart.
Yes, the pericardium, that protective sac. Inflammation here can be caused by viruses too, like flu or COVID are mentioned, or sometimes bacteria. Key signs include pleuritic chest pain, sharp pain that often worsens with deep breaths or lying down, and might feel better sitting up and leaning forward. Also, a new or worsening pericardial effusion, fluid buildup in the sac, specific ECG changes, fever, and a classic finding you might hear with a stethoscope. A pericardial friction rub, a scratchy sound.
Okay. And valvular disease is about the heart's valves themselves not working right.
Right. Either they don't open properly, stenosis, or they don't close properly, leading to blood leaking backward, regurgitation. This puts extra strain on the heart chambers and can eventually lead to heart failure, affecting either the left or right side, depending on the valve involved. The sources specifically mention that left-sided failure often causes fluid backup into the lungs, leading to crackles heard during breathing assessment.
Which brings us to heart failure, HF itself, defined broadly as the heart just not being able to keep up, either with filling or pumping.
Pretty much. The inability of the heart to fill adequately or eject blood effectively enough to meet the body's demands. Management often involves a combination of medications. Beta blockers are mentioned, with a reminder to check pulse first. Aldosterone antagonist diuretics like spironolactone, ACE inhibitors, and sometimes digoxin.
And the sources detail some really key nursing interventions for managing heart failure patients. Very practical stuff.
Extremely practical and important. Monitoring intake and output, INOs, meticulously. Checking vital signs regularly. Monitoring heart rhythm and rate. And crucially, daily weights. This is highlighted calling the doctor if the patient gains more than 3 pounds in a day, as that's a major sign of worsening fluid retention. Assessing skin, temperature, pulses. Fall precautions are important due to potential dizziness or weakness. Listening for that dry, persistent cough that can be a side effect of ACE inhibitors. Monitoring lab results. Screening for depression, which is common. Assessing activity tolerance. Providing oxygen if needed. Positioning the patient upright, high Fowlers, helps breathing. Administering medications correctly. And very important dietary counseling. Decreased sodium intake, decreased fat, and often a fluid restriction to manage volume overload.
That's a comprehensive picture of managing HF. Okay, so we've done the pump, the electrics, the structure. What about the pipes, the vascular network itself?
Right, the final major piece. The diseases affecting the arteries and veins, the vessels that carry the blood. The sources touch again on atherosclerosis, that plaque buildup, and arteriosclerosis, the general hardening and thickening of arteries, linking back to CAD and other issues. Management focuses on things like controlling blood pressure, lifestyle changes, and definitely stopping smoking.
And high blood pressure, hypertension specifically, defined in the sources as 30, 30, 80 or higher.
Yes. Risk factors mentioned include race, gender, and socioeconomic status. Hypertension is often called the silent killer because it frequently has no symptoms early on. But if symptoms do occur, they might include headache, vision changes, dizziness, fatigue, shortness of breath, chest pain, nosebleeds, or signs of kidney dysfunction.
Management involves a big focus on lifestyle, doesn't it?
Huge focus. Weight management, adopting a healthy diet like the DAH diet, avoiding excessive alcohol, regular exercise, stress management techniques, and then medications, of course, diuretics, various types of antihypertensives.
And the nursing role emphasizes helping people stick with their meds and lifestyle changes, teaching home BP monitoring, and being vigilant for serious complications.
Exactly. Complications like a hypertensive crisis, dangerously high BP, stroke, kidney failure, or heart problems like systolic dysfunction or dilated cardiomyopathy over time.
And bringing back Mr. Smith again, his case illustrates how that prolonged increased afterload from his hypertension puts that long-term stress on his vessels, directly increasing his risk for things like stroke or heart damage. It reinforces that BP vascular health link.
It really does. Then we move out to the peripheral arterial disease, PAD. This is about blockages in the arteries supplying blood to the limbs, most commonly the legs.
And the classic symptom highlighted is intermittent claudication.
That's the hallmark, yes. Pain, typically in the calf muscles, that comes on predictably with a certain amount of walking or activity and is relieved fairly quickly by stopping and resting. It's due to the muscles not getting enough oxygen during exertion because of the narrowed arteries.
And diagnosis involves the ankle brachial index, comparing ankle BP to arm BP.
Right. Normally, ankle pressure should be similar to or slightly higher than arm pressure. In PAD, the ankle pressure is lower, indicating reduced blood flow to the leg. A lower ABI value means more severe PAD.
The sources also list some very specific signs and symptoms to look for with PAD. They paint quite a picture.
They do. Pulses in the feet, dorsalis pedis, posterior tibial, might be weak or completely absent. The skin on the affected leg might look dry, thin, shiny, and often has hair loss. The leg's color might be pallor, especially when elevated, and it feels cool to the touch compared to the other leg. Interestingly, because arterial blood flow is the problem, there's typically no edema or swelling.
And the pain. Besides claudication.
Besides the intermittent claudication, described as sharp pain with activity relieved by rest, in more severe PAD, patients might have pain even at rest particularly at night when lying flat or elevating the leg. This rest pain is a bad sign. Also, because of the poor circulation, wounds or ulcers can develop, often on the toes or the top of the feet, and they tend to heal poorly, sometimes leading to gangrene or necrosis, tissue death appearing as black eschar.
And a key treatment point mentioned for managing pain is positioning.
Yes, a crucial point. Encourage patients to dangle their feet down over the side of the bed or sit in a chair. Gravity helps pull blood down into the legs. Elevating the legs, which you might do for venous problems, actually makes PAD pain worse because it fights against the already poor arterial flow.
Good distinction. And nursing assessment focuses on comparing both legs.
Absolutely. Bilateral comparison is key. Checking BP in both arms, checking pulses in both legs, comparing strength, visually inspecting the skin, checking temperature differences, assessing muscle tone, and getting a detailed pain history.
Okay. Then there's carotid artery disease. Blockages in the neck arteries supplying the brain.
Right. Vessel wall thickening and plaque buildup, specifically in the carotid arteries.
Yeah.
And the sources draw a very direct, very critical line here. The manifestations of significant carotid artery disease are often the warning signs or symptoms of a stroke, or TIA, transient ischemic attack.
And they list those signs explicitly.
Yes, very clearly. Sudden slurred speech or difficulty speaking, dysarthria or aphasia, sudden weakness or numbness, especially on one side of the body, hemiparesis, a sudden severe headache with no known cause, sudden vision loss or changes in one or both eyes, facial drooping on one side, sudden dizziness, loss of balance, or coordination problems.
And the required action if someone shows these signs?
Unmistakably urgent. Call rapid response or emergency services immediately. Time is critical in stroke. Time is brain. Recognizing these signs and acting fast is paramount.
Absolutely. Okay, next is aortic artery disease, focusing on aneurysms, a weakening and bulging of the aorta.
Yes, the aorta is the body's main artery coming off the heart. An aneurysm involves a weakening in the middle layer of the artery wall, causing it to balloon outwards or widen. The key point emphasized in the sources is that aortic aneurysms, whether in the chest, thoracic, or abdominal, are often asymptomatic. People may not know they have one.
Until something catastrophic happens.
Exactly. They often aren't detected until they start to leak, dissect, or the layers of the artery wall tear apart, or rupture completely. A rupture is a massive, life-threatening hemorrhage. The sources mention that a sign of rupture, particularly of an abdominal aortic aneurysm, GPA, can be sudden, severe pain, often felt in the low back or abdomen, along with signs of shock due to extreme blood loss.
Very dangerous because they're silent. Finally, deep vein thrombosis, DVT. This is about clots forming in the veins, usually deep in the legs.
Correct. Clots, or thrombi, forming in the deep venous system. The sources introduce Virchow's triad as the classic model for understanding the three main factors that contribute to DVT formation.
Virchow's triad, what are the three parts?
First is hypercoagulability conditions that make the blood more prone to clotting than usual. This could be genetic due to certain diseases like cancer or related to medications like oral contraceptives.
Okay, thicker or stickier blood.
Second is stasis slowing, or pooling of blood flow in the veins. This happens with immobility, like being on bed rest after surgery, long travel without moving, paralysis, or even conditions like heart failure that cause venous congestion.
Makes sense. Stagnant blood clots easier.
And the third part is endothelial injury damage to the inner lining of the blood vessel wall. This can happen due to surgery, trauma, insertion of 5E catheters, inflammation, or certain chronic conditions. Damage to the lining creates a rough surface where clots are more likely to start forming.
So hypercoagulability, stasis, and endothelial injury, Virchow's triad, and preventing DVT is a major focus.
Huge focus, especially in hospitalized patients or those with risk factors. Prevention strategies include encouraging early ambulation, getting people up and walking, using venous thromboembolism, VTE, prophylaxis, which can be mechanical, like compression stockings or sequential compression devices, or pharmacological, using anticoagulant medications like heparin or Levinox.
And if someone is suspected of having a DVT, what does assessment involve?
Checking vital signs, monitoring oxygen saturation, because a DVT can break off and become a PE, carefully comparing the right and left extremities, looking for swelling, redness, warmth, tenderness in one leg compared to the other. Gentle palpation of the calf muscle might be done, though aggressive massage is avoided. Monitoring relevant lab results, especially coagulation studies if the person is on anticoagulants. And always being vigilant for signs of bleeding, which is the main risk of anticoagulant therapy.
Wow. Okay, that was quite the journey through the sources. We've really covered the ground, haven't we? From the basic mechanics of the heart's pump through its intricate electrical wiring and how we read it with an ECG, then the various diseases affecting the heart muscle, valves in the pericardial sac, and finally exploring the crucial network of arteries and veins and the problems that can arise there, like blockages, aneurysms, and clots.
We really have, and pulling all these detailed pieces together, understanding how they connect. That's where the real value lies for you, listening in.
Exactly, because understanding these core mechanisms and common problems, all drawn directly from this detailed source material, it helps you in practical ways. Like recognizing potential issues sooner, knowing those specific signs of a stroke from the carotid artery section, or being able to describe chest pain more accurately based on the CAD patterns, that's potentially life-saving knowledge.
It also provides that deeper why behind common health advice. Why managing blood pressure is so critical, because you understand its direct impact on afterload and long-term vessel stress, like we saw with Mr. Smith. Why things like smoking or diet keep showing up as risk factors across CAD, hypertension, PAD. Even understanding how something seemingly unrelated, like oral hygiene, pops up as a risk factor for infective endocarditis. It connects the dots.
Yeah, it absolutely does. And I think it also empowers you to have more informed conversations with doctors or nurses, right? If you understand terms like preload or afterload, or you grasp why daily weights are so vital in heart failure, or why blood thinners are standard for AFib because of that specific clot risk we discussed. Having that background from the sources lets you engage more actively, ask better questions, understand the rationale behind your care.
Definitely. It helps you contextualize your own situation, maybe based on family history or existing conditions you might have, against this backdrop of how the system works and what can go wrong.
This deep dive, using the sources you provided, has really highlighted the profound interconnectedness of the whole cardiovascular system.
We've tried to navigate the pump, the wires, the rhythm, the structure, and the vessels, piece by piece, guided by the details in the material.
And hopefully this conversation has pulled out the most important knowledge nuggets, provided some clear explanations, made some memorable connections, helping you feel significantly more informed, more confident about this absolutely critical system in the body.
And as we wrap up, here's something to think about, stemming directly from all these interconnected points we've discussed today. Given how factors like inflammation, lifestyle choices, stress management, even seemingly distant issues like the health of your gums or your body's electrolyte balance can directly influence the heart's mechanics, its electrical stability, and the integrity of your blood vessels. How might your overall approach to well-being, thinking beyond just traditional cardio exercise, actually be a more holistic and perhaps more impactful form of long-term cardiac care than you might have initially realized? Just something to mull over based on the connections we've explored.